Good afternoon, everyone. Welcome to this HPS webinar. I'll just give a couple of people a few minutes to join us, so bear with us. Give them 30 more seconds and we'll kick off. So while we wait, welcome. My name is Catherine Bennett. I'm the Head of Marketing and Communications for the Boss Group, institutional healthcare businesses, including HPS Pharmacies. These educational presentations are, you can contribute to your CPD hours to meet the standards set for professional registration purposes. We're very pleased to bring these to you as they can be used for playback later on. So therefore they are recorded and notes will be available by emailing us following the event. A prompt to do this will be sent to you within 24 hours. So now it gives me pleasure to introduce our speaker for today, who you can see on screen, Robyn Martin. Robyn is the clinical pharmacist for HPS Pharmacies, Midland. Today, Robyn will be discussing the topic of decompensated cirrhosis or liver disease. And the presentation will take approximately 15 to 20 minutes. We will have questions after her presentation, so at the end. If you navigate down to the bottom of your screen, you'll actually see a little bubble. If you move your cursor around, you'll see a little bubble. If you haven't used Zoom before, with a Q&A button. All you need to do is click on that and you can type your questions into the panel. And then Robyn and I will answer them at the end. If though your question is quite complex and you'd like to ask it in person rather than type it out, let us know by raising your hand and we can let the audio come through. So with that, we hope you enjoy this presentation and find it really useful in your practice. I will now hand over to Robyn. Go for it, Robyn. Thanks again for joining us.
Thanks for listening today. I'm talking about decompensated cirrhosis or decompensated liver disease. So cirrhosis is a chronic liver disease associated with progressive fibrosis or scarring. In early stages, it may be reversible if the cause is treated appropriately. So something like hepatitis C can now be treated, and that can help to prevent ongoing issues. In later stages, it's generally irreversible. Patients are commonly admitted to hospital with symptoms of decompensated cirrhosis, which is also known as end-stage liver disease. Once decompensation has occurred, disease progression hastens and it ends up leading to either liver transplantation or, if that's not appropriate, death. So portal hypertension is, like most of the symptoms, are a complication of portal hypertension. So the portal vein transports blood from the intestines to the liver. Portal hypertension occurs due to scar tissue or fibrosis and nodules in the liver, increasing resistance to portal blood flow. So here we have a picture of the liver over here. So as you get the nodules and the scarring forming, blood, when it's coming from the intestines, it has to push harder to get through it. So you have an increase in the portal blood pressure. So that leads to a multitude of other effects. You have splenic artery vasodilation, which causes an effective hypovolemia. We activate neurohormonal markers, the renin-angiotensin system. We get sodium and water retention, which affects the heart, increasing cardiac output, which increases flow through the portal vein. And so it goes on and gets, progressively worse over time. So this increase in portal blood pressure leads to many complications, including gastro-oesophageal varices. The reduced blood flow through the liver increases pressure in the veins in the esophagus and stomach, which causes them to expand and develop varices. Ascites, so you get a buildup of fluid in the abdomen. You can also get an ankle and leg edema, due to that, generalized buildup of fluid. Because there's so much fluid in the abdomen, patients can often present quite nauseous, and that also leads to loss of appetite and weight. Patients also can have easier bleeding and bruising, or a coagulopathy, and you will often see deranged liver function tests, as well as hepatic encephalopathy. So gastro-oesophageal varices. So where you have the blood vessels which are kind of expanding because of the increased pressure, you have the varices, and they're quite friable and may rupture quite easily due to excessive wall tension, and that leads to hematemesis and melena. Varices can be prevented through the use of non-selective beta blockers. So propranolol and carvedilol are the most commonly used ones. They work as they reduce portal hypertension, as they reduce cardiac output and splenic blood flow. Plus, they cause splenic vasoconstriction due to alpha-1 adrenergic effects. Carvedilol has been shown to be more effective at reducing portal pressures due to its alpha antagonism. There has been controversy relating to the use of beta blockers in end-stage disease, with studies showing a worsening of prognosis by both continuing and also ceasing beta blockers. It's been proposed that doses should be reduced or ceased in patients with refractory ascites and systolic blood pressure. Sorry, I am talking about the right thing. Sorry. It's proposed that doses should be reduced or ceased in patients with refractory ascites, as well as systolic blood pressure less than 90 millimeters of mercury, a serum creatinine greater than 150 millimoles per litre, or hyponatremia with a sodium less than 130 millimoles per litre. A variceal band ligation may also be considered in patients who have varices that are likely to rupture, or in patients who are intolerant of beta blockers. Variceal hemorrhage, if it occurs, is a severe and life-threatening complication with an overall mortality rate of 10 to 20%. So variceal hemorrhage requires an emergency endoscopy within 12 hours and an ICU admission. So patients will require volume replacement, and blood transfusions often required due to blood loss. However, the aim for hemoglobin is only 70 to 80 grams per litre, as aiming for higher hemoglobin levels is actually associated with a greater level of complications. Endoscopic treatment used will depend on the site of the bleed. So esophageal varices are often treated with endoscopic band ligation, whereas gastric varices are managed by a local injection of cyanoacrylate. And there's quite a few other things they can do with extensive bleeds, which is quite interesting, but kind of beyond the scope of what we'll talk about today. Terlipressin or octreotide infusions may also be used for up to 5 days to help prevent rebleeds. And I guess just a reminder, terlipressin can sometimes be charted as the base, which is 0.85 milligrams, or the terlipressin acetate, which is 1 milligrams. So both of them are equivalent, but it all depends on your prescriber as to what you're going to see on your chart. And sometimes in the same hospital, you might get both prescribed. On to ascites. Ascites is a buildup of fluid in the abdomen. The prognosis once ascites develops is poor, with a survival rate of 30% at 5 years. It occurs due to a combination of portal hypertension, low albumin levels, and enhanced sodium retention by the kidneys. Treatments are aimed at controlling symptoms and include restriction of sodium, adequate protein intake, diuretics, and paracentesis with albumin. Refractory ascites may require transjugular intrahepatic portosystemic shunts or TIPS, or end-stage liver transplantation. So just with the TIPS, in a patient who has not just has portal hypertension, you have the poor blood flow going into the liver and causing increased pressure and ascites and all the rest. So a TIPS stent is just a little stent or shunt between the hepatic vein and the portal vein, which helps to reduce the pressure within the liver and the rest of the portal hypertension, essentially. So with ascites, the retention of sodium leads to fluid retention. So a reduced sodium diet is useful. A reduced sodium diet is one where people don't add salt to food whilst they're cooking or before eating, and avoiding diets high in processed foods that are high in salt. We also want to avoid medications that cause sodium retention. So things like anti-inflammatory, non-steroidal anti-inflammatory drugs, and effervescent preparations, antacids, and also penicillins, as they all contain lots of sodium. Secondary hyperaldosteronism is a significant cause of renal sodium retention in these patients. So because of that, spironolactone is the first line diuretic in these patients. With spironolactone, doses usually start at 50 milligrams per day and increase from there up to sort of 400 milligrams. Amiloride can be used, and it's often used in patients who can't tolerate spironolactone, usually because of gynecomastia. If you're not getting enough of a diuretic response from either the spironolactone or amiloride, then we add on a loop diuretic. So normally furosemide, 40 milligrams once a day, and then increasing up. And of course, we monitor sodium, potassium, and creatinine levels with these patients, particularly as we add on more diuretics. So refractory ascites is when fluid can't be removed or prevented despite salt restriction and diuretics. Paracentesis is required in these patients to remove the fluid. So paracentesis is also sometimes called an acidic tap, and it's literally putting in a cannula under the skin to drain off that excess fluid. Removal of the fluid can make patients feel more comfortable, reduce nausea, and improve appetite. Sometimes people will talk about large volume paracentesis, and that's considered to be the drainage of 5 to 10 litres of acidic fluid in sort of 1 to 6 hours. After each litre of fluids removed, albumin 20%, sort of 8 grams, which is a standard vial from blood bank, is given. And that helps to reduce complications due to fluid shifts and improve survival. Albumin levels are generally low in these patients because the liver can't produce enough albumin. So having an increase can help to keep the patient feeling a bit better for a bit longer as well. Because we're retaining sodium and water, of course, ankle and leg edema may also occur. Hepatic encephalopathy is the next kind of common symptom that we see causing admission into hospital. It's characterised by a range of neuropsychiatric signs and symptoms. It's believed to occur due to toxins such as ammonia and glutamine crossing the blood-brain barrier. Hepatic encephalopathy may be classified as either covert or overt, depending on the degree of symptoms. So covert symptoms are more subtle and may require specialised testing to detect. They include subtle personality changes, problems sleeping, or impaired decision-making skills. I think generally in hospital, we have patients who are admitted with more overt symptoms, such as Ascites, which is a flapping tremor that's diagnostic for hepatic encephalopathy, disorientation, confusion, drowsiness, unconsciousness, or coma. The treatment is aimed at reducing toxins. So lactulose is the first line agent. It's started at 30 mils 3 to 4 times a day with the aim of producing 2 to 3 semi-soft stools per day. So we don't want to give patients diarrhea, but we do want them to be moving their bowels regularly each day. For patients who don't like lactulose, macrogol can be used as an alternative. If the lactulose or macrogol isn't sufficient to prevent hepatic encephalopathy, patients can take rifaximin 550 milligrams twice a day to help prevent it. Protein restriction is not recommended in these patients because whilst it might reduce the ammonia production, it also wouldn't have any effect on the patient's general well-being. So protein intake is associated with improving skeletal mass even, which reduces the encephalopathy risk. So coagulopathy, traditional markers of coagulopathy, such as the International Normalized Ratio or INR and prothrombin time, do not predict the bleeding risk accurately in cirrhotic patients. So these patients may have an increased clotting risk in spite of the raised INR or prothrombin time. Portal vein thrombosis may occur in up to 25% of cirrhotic patients. And in these patients, it's quite tricky because we really need to balance the bleeding risk with the risk of extension of the thrombus. In patients who have decompensated cirrhosis, we need to use unfractionated or low molecular weight heparin. We can use apixaban and dabigatran in Child-Pugh class B. In class C, no oral anticoagulants should be used. And infections are also a common cause of decompensation. Spontaneous bacterial peritonitis is most concerning, as if patients develop it, they have a mortality rate of 40 to 70%. E. coli and other gram-positive cocci are the most common bacterial causes. So for patients who have an acidic tap, the acidic fluid will be cultured just to make sure that there's no bacterial growth. In patients, if they're not quite sure what's going on and whether there is infection present, they'll consider the use of empirical intravenous antibiotics. So ceftriaxone 2 grams daily or cefotaxime 2 grams 3 times a day. And I guess it's worth starting something, until proven otherwise, as the mortality risk is so high. So decompensated cirrhosis is a complex illness which may be difficult to manage as the disease progresses. It's commonly seen in acute medical units with patients commonly presenting, I've lost light. Here we go. With patients commonly presenting with hepatic encephalopathy or ascites. So let me go down. Thank you very much for listening. And if you have any questions, please pop them in the chat box.
Thank you, Robyn.
Thank you.
If you have any questions, please just pop them into the chat box. If you're watching this as a recording, please feel free to send any questions through to our team, as you'll be prompted with the email address at the end of the presentation. Okay, well, we may not have any questions, so it looks like you might have covered all the materials sufficiently, Robyn. That's wonderful. Thank you very much for your time, and thank you to those who have joined us. We look forward to bringing some more of these to you in future. Please stay abreast of the latest topics. They will be up on our Knowledge Centre, and you'll receive notifications occasionally through posters that are put up around your site. After you log out, you'll be prompted to provide your feedback on this recording or this seminar. It would be greatly appreciated if you could take some time to provide us with your feedback, as it will always help us guide future events. Thank you again, and thank you again very much, Robyn, for taking the time to present.
That's okay, thank you.
Thanks, bye.
Bye.